Hi, everyone. I am Rachel Warner. I'm the Executive Director of Penn's Leonard Davis Institute of Health Economics. Welcome to our kickoff seminar for our new academic year. Today, we will be talking about state innovation in controlling healthcare costs in consolidated markets. It's a big and important topic, so I want to get started right away so we have plenty of time to talk about it. We've lined up a really great group of panelists to tell you what they know about it today. With that, let me introduce today's panelists. Lauren Adler is a fellow and associate director for the Brookings Schaefer Initiative for Health Policy. Natasha Murphy is director of health policy at the Center for American Progress and previously worked at Care First Blue Cross Blue Shield. January Angeles is managing director at Baylett Health. She previously worked in the Rhode Island Medicaid program and as CHIP director for Rhode Island. And our fourth panelist is Martin Gaynor, who is the E.J. Barone University Professor of Economics and Public Policy at Carnegie Mellon University. He's also the former director of the Bureau of Economics at the U.S. Federal Trade Commission. Our moderator today is LDI Senior Fellow Allison Hoffman. She is a professor of law at the University of Pennsylvania Carey Law School. Her expertise is in insurance regulation and health policy. And with that, Allison, I will turn it over to your excellent hands.
Great. Thank you, Rachel. Thank you for inviting me to be here today and to help to moderate this conversation between a group of really insightful and interesting people. So today we're talking about an important topic. It's at the nexus of two trends going on in healthcare. One is increased consolidation and the other is rising costs. And neither of these are new. Both have been accelerating. Between 1998 and 2021, mergers have reduced the number of hospitals, for example, in the country from about 8,000 down to about 6,000. And this is just one sliver of the picture of consolidation, which many of you on this call know. It's resulted in a smaller number of more powerful health systems. Unsurprisingly, over this period, healthcare costs in the US continue to outpace economic growth. Between 1970 and 2019, total US health spending grew from 7% to about 18% of the GDP, over $4 trillion a year. And decades of evidence generally points to price as the important driver of healthcare spending growth. It's not primarily increased use of care. Obviously, either one of those could drive up spending. Price increases following consolidation, unfortunately, don't seem to produce improvements in the quality of care. So as we're thinking about how to tackle healthcare costs, there are lots of different players you could think about. The federal government plays a role, obviously, through Medicare and Medicaid policies. But today we're going to focus on something different. We're going to focus on tools available at the state level. A few states have been experimenting with ways to address healthcare costs, but there's not an obvious solution. So we have a lot of questions about what works and what doesn't. States have a lot of tools, and they are also constrained in some important ways. For example, a legal constraint is ERISA, which is a federal law which prevents states from directly regulating most employer-sponsored health plans. And so we'll make sure in our discussion to reserve time to talk about legal and other barriers as we also talk about opportunities. So I'm going to pose some questions to our panelists, and I'll kind of ask each one of them a question, and then I'll put a couple questions out there for the group of them. And I also want to draw in questions from you all who are participants on this call. So please put your questions in Q&A, and to the extent I can, I will weave those into the conversation as well. So with that, Lauren, I'd like to turn to you and ask you to kind of give us a roadmap for the conversation today. Can you start us off with this 30,000-foot view on what kinds of tools are available to state governments to control healthcare prices? So I know in your work, you've talked about two types of interventions: direct government price regulation on the one hand, strategies to design market and foster market competition on the other. So how should we think about these buckets and the types of policies in each, and where those kinds of policies tend to be targeted? To whom are they targeted? Hospitals, providers, towards drugs, other payers, others?
So I think that's right. I think at the 30,000-foot level, it's important to sort of set the stage that there's generally two buckets, right? There's sort of you can go after, let's improve competition, let's sort of make markets work better. That market pressure can help, keep some sort of control on prices and in theory, sort of encourage higher quality care as well. And then failing that to some degree, or to the extent that's not possible, there's sort of the price regulation side of the coin here. I do think sort of jumping off of that introduction, one note is, yes, ERISA does prevent states from regulating the sort of self-insured employers and what they pay, but states in general have pretty broad purview over regulation of providers, including licensure, including sort of price regulation. A lot of states haven't really done much of that and don't necessarily have the apparatus set up to do so. But that certainly is in their sort of jurisdiction and power. And then sort of on the enhancing competition front, I mean, another thing that is clearly in their power also is I think first and foremost, right, is sort of better antitrust enforcement or stronger enforcement of mergers. In particular, I think the sort of the biggest group here that probably doesn't get enough scrutiny, even though it does get some, is just the sort of merger between two large hospitals, a horizontal merger in the same region of your state. We have a plethora of evidence at this point that drives up costs without improving quality. Yet some of these mergers are still going through. Certainly this can be tried these sort of can be attempted to be blocked at the federal level, but state attorneys general also have that power. I think we talk mostly about hospitals here, but there is sort of the physician side here, which has gotten more attention. And on that side, where there probably is value in better reporting on a lot of the sort of smaller mergers that happen. So a hospital who buys up 20 different orthopedic practices in the area, or a private equity company who does something similar, a lot of those acquisitions are too small to trigger the sort of reporting threshold where the company has to tell regulators about it. But states could certainly change that and sort of require those to be reported to them. And then sort of on the hospital merger front, to close up, I think one big thing for states is simply not to use certificates of public advantage or COPAs, which states have often used to basically stop the federal government from trying to stop a merger that we view as pretty clearly anti-competitive, on the grounds that somehow the state will kind of oversee things and make sure it doesn't go poorly. But the track record is pretty abysmal in actually sort of following through and preventing abuses of market power there. I think there's sort of the next step down from that, which is, once the merger's already happened, and there's, right, some of this is like the cat's out of the bag already. We already have giant health systems in many states across the country, right? You could try to kind of focus on some of the anti-competitive contracting clauses that exist out there. So California made some hay under Attorney General Becerra when he was there on some of these anti-steering clauses here. But basically, there's a handful of clauses that sort of high market power hospital systems will try to use to basically get even higher prices, sort of all or nothing contracting, where they make you go with their physicians and that sort of thing as well and contract with them. And most favored nation clauses that, on the flip side, that insurers will often use to sort of say, every provider has to give me, I'm the big Blue Cross plan or whatever in the state, you have to give me the best price. And that one actually applies on the drug side of the coin as well, even though I'm going to mostly focus on, they're very similar clauses in the drug context as well there. I think I briefly mentioned COPAs, or certificates of public advantage, but there's other of these sort of state laws that have the effect of weakening competition. So there's a handful of states that still have any willing provider laws, or that set up certificates of need that basically prevent new competition from entering a market. And that, we think of that most importantly in the hospital context, but it could be in the nursing home. There's a sort of any sort of facility or physician practice where that might apply, and really sort of anything that limits competition among providers here is generally going to be, to have sort of negative effects on these markets. And then, right, I think there's some question here of, can you set up some sort of independent agency to define anti-competitive conduct and limit mergers? I know Oregon has been trying this. But there's certainly avenues to do that. I think some of the issues is hospitals tend to be very powerful politically at the state level. So how independent can you really make it is a question, but I do think there's some avenue to potentially creating some sort of independent board. And then lastly, on the sort of competition front, right? There's just a fair amount of, scope of practice expansion, basically allowing more competition in your physician markets by allowing more nurse practitioners and such to sort of practice to the top of their license, can similarly have pro-competitive effects here. And now sort of in the newer world of lots of more telehealth and sort of crossing states and sort of entering into, increasing access in rural areas, it can be useful as well. Now, having said all of this about increasing competition, I did sort of allude to the fact that, right, the cat's out of the bag in a certain sense with hospitals, and we already have very powerful health systems. And, while I guess it's plausible to break up health systems, that doesn't seem to be in the cards. So, once you have these systems, the kind of oversight mechanism plausibly could be, okay, let's step in and effectively regulate prices. And that can look a lot of different ways. So, right, you can try to literally pick the price for every service. That's somewhat difficult. I mean, it is what the Medicare program federally does. Or you can try to sort of, maybe carve off the right tail kind of thing, right? You set sort of a limit on how high prices can be. So you're really trying to sort of focus your attention on sort of like the highest price providers that are out there. I mean, the most common method that sort of seems to exist out there is just creating a state public option. So if you create a public option in your state and you set the prices or sort of regulate the prices that public option pays to providers and in particular hospitals, that can certainly reduce the premiums of the public option itself, but also to the extent that is competitive with other plans, it basically gives leverage to the other private plans in the market to also bring down prices, because they can now credibly say, look, no one's going to enroll in my plan if I can't be competitive on premium. So hospital X, you need to give me a more reasonable price in this setting. So that certainly has that. There is a risk there, though, because if you set the prices too high in the public option while still being competitive, you actually can have the sort of opposite effect and potentially increase prices in other plans. That is where it leads me to, there's sort of one option here that I don't think any state has sort of taken up yet, but you can create sort of a default contract, as we tend to term it, where basically you say any commercial plan can pick, they can agree to pay 200% of Medicare to hospitals, and the hospital has to accept that. There's no ifs, ands, or buts. They have to accept it. They have to offer access. And then that's sort of, if that is on the table, the plan and the provider can then negotiate whatever actual structure of contract they want. But the plan has a clear walk away that if it's going to cost me more than the default contract, I'm not going to play ball. And that sort of has, I think, sort of the cleanest way to sort of handle this issue. And then one more note on the public option, just because so far states have focused this only on the sort of sliver that is the individual market. There's nothing stopping a state from going further, right? You could offer a public option to self-insured employers in your state. You could create it and say it is an option, right? So you're not forcing them to do so. But that would obviously have a much bigger effect. There's, actually don't remember the latest number, but 165 million or so people in employer plans, and 12 million or so in individual market plans. So just the relative sizes here obviously are very important here. I think those are kind of, if you're really trying to address prices and high prices and really reduce premiums, those are really the sort of options that are kind of like going to have the most bang for your buck. And obviously states can then use some of the savings generated from these and reduce premiums and, get a waiver, 1332 waiver from the government and use some of these savings to increase Medicaid rates for certain services or help out financially strapped hospitals and that sort of thing. There are the other, just sort of touch on, I think, some of the other avenues. So some states have used the insurance rate review process to try to get at this, where they'll say, if premiums grow faster than X%, we get to review it. Rhode Island has sort of stood out for saying, if we don't like what's happening, basically, we can then sort of step in and regulate the sort of provider side or the hospital side of that sort of premium increase as well. The one downside here is, right, that is because it's insurance rate review, ERISA does kick in here. So they're only going to be able to do that for the fully insured plans. And I think there's some question of whether you're just sort of squeezing the balloon in that situation. And, because the sort of negotiations are often happening between self-insured and fully insured all at once, it's sort of unclear exactly how that shakes out in the end. And then lastly, I just wanted to touch on is, right, states also have a lot of purchasing power. They, for one, have a state employee plan that often has, depends on the state, but often has a lot of people in it, right? That gives you a lot of power to sort of set rates or try to negotiate harder for the rates in that plan. It also sort of gives leverage. The fact that the state is a purchaser of so much medical care gives them leverage in these other contexts to be more demanding under a public option, or an individual market, and sort of regulating their individual market prices side of things, because providers need so much of that state revenue is coming from Medicaid or state employee plans.
Lauren, that is super helpful. Thank you so much. I'm glad you came back around to the public option question, because I was going to push you on that piece a little bit. And thinking about employer public options is something that I think is useful. It's something I've written about. So I'm glad you brought that in too. And as I hear you talk, and I think we'll have a chance to talk about this more, one of the things that occurs to me is a number of these things may be necessary kind of together rather than individually, in order to keep in order to prevent that squeezing of the balloon, right, where dollars move from one place to the other. But let me pull a couple more people into the conversation. Natasha, can you help me think through with this group some more concrete examples? So I know in recent work, you've examined two high-profile strategies. You've thought about state healthcare cost commissions and the role of state attorneys general. So could you talk a little bit in particular about how state healthcare cost commissions work, how they advance affordability, how they can improve health equity while thinking about high healthcare costs? Massachusetts has led the way in this, but has joined by at least 8 other states who established these statewide cost commissions. So can you tell us a little bit about how they approach cost control, what kinds of teeth they have in terms of compliance, and where you see the successes so far?
Yeah, certainly, Allison. So I think, as we've mentioned, healthcare affordability and rising healthcare costs has become such a priority for our state level officials and policymakers. So I know in nearly every state, it's health and hospital spending that has consistently ranked among, the top 5 expenditures. And so there really is a focus on addressing these rising healthcare costs, which are not only compromising residents' ability to access care due to, greater out-of-pocket expenses and premiums, but it's also constraining financial resources for the state themselves as they try to advance other priorities. And so in response, you have a growing number of states, kind of 8 plus, who have pursued cost commissions, to both improve affordability for their residents while also advancing health quality and equity, which I think is an incredibly important 2-pronged approach to ensure that, by attempting to solve one problem, we're not exacerbating some of the existing inequities that we already see in the system. And so while the commission specifics across these states can vary, whether it's enforcement authority, their design, their policy goals, they vary by jurisdiction because that's the nature of, state health policy. Generally, I view state cost commissions as, a state developed entity that's been tasked with setting, monitoring, analyzing, and regulating healthcare costs. And over time, I think these state cost commissions have really emerged as an attractive policy option due to the various cost containment strategies that they can employ. So at their core, and I think one of the most common shared elements across these 8 plus state commissions that currently exist is the ability for them to set a cost growth benchmark. And so those are the annual rate of growth target for healthcare costs and expenditures within a given state. And so across states, we can see the nomenclature will vary. Some states like Massachusetts and Connecticut will use benchmark. Others like California and Rhode Island are, using the term target. But, overall, it's really designed to capture that year-over-year rate of growth. And these targets really serve as an anchor point to not only better understand, but also to clearly be able to fully track healthcare costs. And one of the key elements that has been really, really pivotal is the ability to have this data be accessible and be reviewable over time. But in addition to that, it's the ability for this data to be made publicly available. So many states, Massachusetts included, will publish this information on an annual basis. And by making it publicly available, it's describing, some of the cost drivers based on input from stakeholders in the system. So whether it be hospitals, insurers. And this additional transparency can be incredibly powerful and arming, not only healthcare policymakers and decision makers, but even the general public in some of the underlying costs of care. But in addition, this data is really helpful in kind of informing future market interventions and developing additional policy recommendations that can help hold, healthcare parties accountable to reducing prices. But also, kind of as Lauren mentioned, another cost containment strategy for these cost commissions is their ability to combat market consolidation and improve competition. So there are certain cost commissions that actually are enabled and authorized to monitor hospital and provider consolidation. And so they have the ability to conduct administrative review of mergers in an effort to try and limit some of the anti-competitive practices that we've seen that Lauren mentioned, some of the anti-steering, anti-tiering. But kind of conversely, and in support of those efforts to control costs, it's really, really pivotal that some of our kind of next generation cost commissions, such as what we've seen in Oregon and California, are equally prioritizing healthcare quality and equity. Because as we know, having a singular focus on costs alone can sometimes have that unintended consequence of an adverse impact on health equity, as cost shifts and utilization might change for populations who have, previously been marginalized. But Oregon and California have really taken a concerted focus on equity. And so in Oregon in particular, I know they focus a lot of their cost analysis on utilization across different ethnic and racial groups to gain a better understanding of, kind of the utilization patterns there, but also trying to recognize if there's any impact as they kind of explore and implement some of these cost containment measures. And then kind of moving forward for additional states who are looking to pursue these commissions or establish their own cost growth benchmark programs, they can definitely learn from the successes from their sister states. And some of the best practices that have been identified thus far to really ensure that these cost commissions are impactful, it really does start with the design. So you have certain states who have made a decision to leverage existing entities, whether that's in their office of the superintendent for insurance, or if it's, a part of the AG's office, or even, the health department. They will leverage existing resources to better understand healthcare costs in their state, whereas others will actually establish an independent entity, and that's, a body of experts who really are setting and reviewing those targets. And so while there's, pros and cons to both of those, it's always great, particularly for states with limited resources, to repurpose some of their existing personnel. There's a lot of power in having an independent entity that, is not subject to the whim of changing administrations. And it kind of improves the long-term sustainability and viability of, a cost growth program or a state cost commission. Another important element in design is identifying a consistent funding source for these programs to ensure that it's not dependent on, year over year legislative activity, given, kind of the changing politics in a lot of entities. Another key component design consideration is around enforcement authority. And so without the ability to hold healthcare entities accountable in the system in a meaningful way, cost commissions sometimes can be viewed somewhat as just a kind of a data tool or source. And so it's been really important, particularly for some of the post-Massachusetts entities, to learn from Massachusetts' experience. As a state, they have performance improvement plans as well as fines for entities that are consistently failing to meet those cost growth targets. And so it's, having that enforcement authority and the ability to leverage some type of consequence has been really, really important in, kind of the overall efficacy of these programs.
Thank you. That's super interesting. And I want to turn to January to ask you a little bit more about one of the components that state commissions have adopted, which is setting cost growth targets. I know you recently worked with a group of 8 states and created a playbook for state cost growth targets. Can you talk about some of the insights from your work?
Sure. So a lot of the things that are in the playbook are things that already Natasha has touched upon, sort of the design of the target, how you have the governance structure, the importance of data. I think in doing this work, what I've observed is that a lot of people tend to get very, very wrapped up in the target itself, how it's developed, the methodology that's used to set it, what the actual numerical value of the target is. And I think that process is important, but setting a target in and of itself is not going to get you where you need to be. It's a goal. It's a goal that you set, and ultimately you are going to need states and their partnering stakeholders to take action and implement initiatives that will drive spending down, things like the things that Lauren had already mentioned. And so again, like sort of just emphasizing what Natasha already said, what a cost growth target does is it creates transparency, right? And through that transparency, some accountability for entities within that state that have a role in managing healthcare to really make good faith and effective efforts to achieve that target. And so I think that when states are considering establishing a cost growth target, a critical component that is often overlooked is the robust data infrastructure that is needed to get to that transparency, right? To measure and report cost trends in the state, to understand how much is being spent per person on healthcare, how much it's growing, how much spending varies by provider and by payer. What are the types of services that we're spending the bulk of our healthcare dollars on, and how is it price that's driving increases, or is it utilization? I know that there's already a lot of evidence there, certainly nationally, to kind of support this, but it is very, very important to have that at the state level, because that is how you get buy-in. And that is how you get people in the state to coalesce around doing something around healthcare costs, right? And again, as Natasha also said, it is how you identify where you need to focus your cost containment efforts at the state level. So again, it's a goal, and setting that goal is helpful in terms of creating sustained attention on the problem of healthcare costs. But what is actually involved in setting the target is not, I would say, it's not where the real work is at. It is in the transparency and getting the data and information to make the case and build the momentum to take on these initiatives to address healthcare costs. It is in the stakeholder engagement to get providers and payers to coalesce around initiatives that you as a state are trying to push. And so I think that states that are thinking about cost growth targets really need to consider whether they have the capacity and capability to do the transparency piece, because it's a big lift. It is, and in some states, they don't have APCDs to do the kind of analyses that you need to do. And in some states, they have APCDs, but they're untested. And so trying to get that infrastructure to get this effort going, I would say having sort of your eye towards that in terms of setting a cost growth target program is really important.
Thank you, January. Marty, I want to pull you in here, and I want to ask you a couple of things. One is I'd love your thoughts on what you've heard so far and what do you think is most promising at the state level. But I'm also seeing bubbling up in the Q&A a lot of questions about consolidation and what states can do in that front. And in particular, I probably prompted this by how I framed consolidation, which was that I focused on horizontal mergers and hospitals. And people are noting rightly that consolidation is happening in a different way now, which is that it's happening vertically. And we see, for example, we see that hospitals are the number one employer of doctors, followed by insurers, followed by private equity. It's becoming more complex and multidimensional. And people are asking questions about, can states do anything about this, right? We've seen a little bit of the playbook on what states can do, what state attorneys general have done with regard to things like hospitals gobbling up other hospitals. But what about the greater complexity? So both of these for you, just some small questions to kind of wrap up the first round, which is, what do you think about what we've heard so far? And what can states do as consolidation gets more complex?
The health policy of everything. So let me briefly sort of restate that this is a really, really big deal, that We've had a huge amount of consolidation in U.S. healthcare, and Allison stated that at the beginning, but so much so that somewhere between 2/3 or 3/4 of geographic areas in the United States are dominated by one powerful healthcare system. That's really important because what that means, this comes back to something that Lauren said, is one of the key issues then is how do we deal with these dominant systems now that the consolidation has happened? Yes, I don't think we want further consolidation that is harmful to patients, harmful to consumers, harmful to workers. We don't want that, whether it's horizontal or non-horizontal. But I think one of the focuses has to be on how do we deal with these dominant systems. Now, in my view, things have gone so far that in most of these markets, we can't rely on competition anymore to keep prices and costs down or even to assure quality because of the fact we have these dominant entities. Now, as Lauren said, I agree. I think some kind of price regulation is in order. However, I think in most states that's unlikely to happen or unlikely to happen real soon. So we need to think about what we're going to do while we're waiting for that to happen or hoping for that to happen. And one other high level point, even if we do implement price regulation in some places, that doesn't mean we can then ignore promoting competition, because competition over patients is important for assuring quality of care, service, access, things like that. So, and I'm not saying that Lauren meant these things to be independent at all, but I just did want to make that point. So I think public option has some real promise, but of course, states have to think about how they implement that. And one thing they have to do is make it so that providers either want to contract with the public option or feel compelled. This is where the state as purchaser can play a role. States are often the largest employers in the state government. So in Pennsylvania, where I live, the state government is a larger employer in the state, followed by University of Pittsburgh Medical Center. And so the state can say, hey, you want to be in our plan, you have to contract with the public option. That's a possibility. That's something that I think is worth considering, but the design has to be considered carefully. A number of the other panelists also mentioned state monitoring, review, and oversight. I feel that's very important. And without data, there's no information. As January said, data are infrastructure, right? This is the information age. So just like roads are important, airports, sanitation systems, power systems, data are part of our infrastructure, and we're woefully behind with healthcare data. So a number of states do have some good data systems, but that's the minority. And state governments themselves need the information. Employers need the information. Policymakers need the information. I will say I think the data can in some instances be useful to patients or consumers, but I don't expect price transparency, for example, to drive these markets for a variety of reasons. But I think that really where these data are available are providing information to public policymakers and to private decision makers. So I think that's important. And then you have to have a body that engages in monitoring and oversight. And this is something I believe was already mentioned. It has to have teeth. So right now, the state review bodies, for the most part, don't have teeth. Oregon does have a body that can review mergers, and that shows some promise. As was mentioned, guess what? Who is the most powerful political entity in most states, and actually in the entire country? Well, hospitals are one of the most powerful political entities, but that doesn't mean that these things are not worth addressing. So I think, and thinking about this, if we can try to move towards price regulation, I think that's a good thing, but recognizing that's something that likely won't happen soon or might be very difficult to implement in a number of states, there are nonetheless some important things that can be done. And last, I'll say antitrust enforcement still plays an important role. There are areas where, like I said, consolidation has already happened. But as Allison pointed out, what I was referring to in terms of massive consolidation is mostly horizontal, hospital to hospital. A lot of acquisition of physician practices by hospitals that already happened. But that's something where antitrust enforcers can play a role, looking at what insurance companies are doing and so on. And that can be independently. State attorneys general do have the authority to do this, but they can also work closely with federal authorities. And when a federal authority is mulling an antitrust lawsuit, whether the state is on board with that makes an absolutely huge difference in whether that lawsuit goes forward. So that's something important as well. So I'll stop talking at this point because I know Allison, I realize I didn't address all of your questions, but I want to give other folks the opportunity to weigh in. And I know there were a whole bunch of questions.
So before I pivot to some new questions for you all, does anybody else have comments or thoughts after you kind of hear the collective of what people are talking about, of things that you think are exciting, or you want to make sure we continue to kind of tease out in the conversation? Oh yeah, Marty, please.
One thing I didn't mention is this. I think that, as folks pointed out, a number of states are doing things, and that's great. And some of these things are innovative. But I think for the most part, states are underusing their authority. Often state departments of insurance, state departments of health have authorities either in terms of review, gathering information that are not exploited. States as purchasers have been mentioned. I think that there's the potential for states to do a lot more. And it's important, right? Healthcare is the biggest sector in the U.S. economy. It's 1/5 of the entire economy. And the growth in healthcare costs, as much as healthcare has increased in value, it's wonderful in many ways. It's led to stagnation of wages. It's led to increasing inequality. It's led to unemployment or underemployment, and probably to healthcare problems for those folks who have become disadvantaged as a result of that. So this is a huge deal. And I didn't even mention healthcare workers who also face all kinds of problems in these consolidated markets, facing firms who are not just dominant sellers of healthcare, but dominant employers. Outside of that, things are going great.
So one development this week, I think that CMS anticipated our panel. And so they announced this week that a new initiative called the States Advancing All Payer Health Equity Approaches and Development, the AHEAD model, which is a kind of a new program to try to encourage states to apply and to experiment in this space. And so I want to invite, and people have been asking questions in the Q&A about some of the models that I think inspired this initiative, Maryland's payment model and others. So I'd like to invite you all to talk a little bit about what you see this initiative doing, what states might take it up, whether you think it's likely to be effective, what it could produce, or if you think that it's not going to add a lot to what's already going on.
Right. So the AHEAD model is, for those of you who are not familiar, it's a voluntary model with goals of, I think, increasing primary care investment, providing financial stability for hospitals, also enhancing community supports and connections to community resources. And the way it's structured, is set up, is CMS is providing initial funding to support states that participate. Hospital global budget is one of the key components of the model. And that's, I think, the component, like the Maryland model that has come up. I think I've seen it in the chats here. Just a bit of a description, what a hospital global budget is. It's a different way of paying hospitals, where hospitals get a fixed amount of revenue for the year based on a defined population's expected utilization for a set of services, right? And the way hospitals are paid right now, they are chasing volume because that's how they get the revenue. And that was a big problem. We've seen that in the early years of COVID when elective procedures were halted, hospital revenues plummeted. You wouldn't have that under a global budget. Hospitals would have a steady, predictable revenue source. And the idea is that under a global budget, paying hospitals in this way instead of through fee-for-service would give them the incentives to manage care within a budget constraint. How it's going to play out in terms of in the future, I don't know. I am cautiously optimistic, but I think I'm having a little bit of a hard time seeing how CMS might get states beyond those that already have hospital global budgets, like Maryland, Vermont, and Pennsylvania, how they're going to get them to apply. It is a big lift. And I am not certain that the financial incentives to support this implementation is enough. I also think that there are a lot of things, kind of necessary components to being able to do a hospital global budget, right? You have to have, for it to be successful, you have to have the vast majority of your hospitals and the vast majority of the patients in that hospitals to be under a global budget, right? So this needs to be all payer. This needs to be, it's very hard to do it just like kind of on a one-off basis, hospital by hospital basis. And that's difficult to achieve on a voluntary basis. You need to have strong regulatory structures to get there. And Maryland is the model that has been mentioned quite a bit. Maryland has payment regulatory authority, like it regulates payments for hospitals, and that is part of how they're able to be successful. And a lot of, as Martin said, a lot of these kinds of regulatory levers states aren't using and taking advantage of enough. So I think you kind of have to have that sort of infrastructure first.
I might just add a couple things. So people either may not have been around, may not remember that at one point there were quite a few states that had all payer rate regulation. That it wasn't universal by any means. And the evidence is that it's not clear how well it worked, quite frankly. It looked like it worked kind of okay in a few places. In many places, it didn't actually seem to work terribly well. It doesn't mean we shouldn't strongly consider and maybe advocate for price regulation or rate regulation or global budgets, something like that. But I think we do have to be aware of that. It's not so easy to make work. And with regard to global budget, we have to be aware that while you're regulating the total amount, not just the price, so quantity can't move to drive up costs. You have the incentives are the opposite. Under rate regulation, if the price is high enough, the incentive can be to do more. But under a global budget, the incentive is do as little as possible. And so you have to be aware of that and think about ways to counteract that, particularly if hospitals aren't facing strong competition. So if patients and doctors who refer them don't have a lot of other places to refer patients to, if a hospital under a global budget kind of lets this slide, lets that slide, let this slide, then you may have a problem. So I'm not saying we shouldn't do it. Don't get me wrong, but I think consideration has to be given to these points, and we do need to look back a little bit to be aware of the fact there is some history here, and we need to do what we can to learn lessons from that.
Just to jump on, Marty made the main point I was going to try to make, that like we do have experience with this, and it generally didn't work. Right, but one, like all the states basically abandoned it, other than Maryland. So right, it is. That is of note. It is, and I think just right, this is very difficult. That is important. This is a lot of work to do. And even Maryland's, which is sort of held up as the most successful, lasted the longest. Doesn't look like that's really affecting costs much or anything like that, right? It's fundamentally the same political problem that prevents states from, going after, stricter antitrust enforcement also applies here, right? If you set up a ongoing sort of, we're going to set hospital rates and stuff like that, you're going to be subject to the same political pressures. And I think that's why we've seen states not actually be tough. And in some cases, some of the experience of previous states, I think, be more lenient with sort of rate increases than otherwise might have happened. Right. I think that's what leads me to either the sort of like pick or like do some sort of default contract where you're trying to slice off the right tail and just sort of pick a number, a percentage of Medicare or something like that, and just go with it, because I think the sort of continued approach is very difficult. I think it's not, I don't want to say like you can't do it, but it is just that it's a lot of work and a lot of very difficult political effort to be put in. And again, I should say, like, price isn't the only factor here, right? If you think you can, right, if you think you're holding price constant, but you're improving the quality of care and you're getting more integrated care, that obviously can be worth it too. But again, sort of leads to this is not simple business.
there's a question in the Q&A that I want to draw in that that builds on this and builds on, I think, what CMS would ideally like the AHEAD model to do, which is to think about questions of health equity. And in particular, a lot of what the outline of AHEAD talks about is increasing investments in primary care, and doing that in part to think about greater access and addressing kind of needs in a different way within communities. We have a question in the Q&A which is focused specifically on healthcare, state healthcare cost commissions and what they could do to improve health equity. To talk a little bit more about that and how you would measure it. How would you know if you're improving health equity or not? But I want to ask it more broadly as well, as you think about any of these kinds of state approaches, or or CMS's vision of what states might do, especially with investments in primary care. Where do you think states have the best levers to think about these questions, and how would you measure it? How would you think about whether they're effectively achieving that goal or not?
I'll just say something briefly. One, I think I agree. I think health equity is obviously important, and it's something that state should be working on. I think we have to be cautious of asking entities to do too many things at once, and a state health cost commission might not be the right place to get at this. I think that states need to think about direct provision or subsidies. We need to increase access, and we need to have providers where people are. And of course, the folks among us, our friends and neighbors who are the most disadvantaged, often face significant barriers to care. And so I think the states need to think about funding community health centers, community health clinics, nurse practitioners to get out there in the community. And I think direct provision, or at least paying for these things, is an important thing to do. And that doesn't strike me as necessarily being a productive thing to ask a healthcare cost commission to do. But I think it's very important.
Yeah, I certainly agree with Marty's feedback that sometimes it can be exceptionally difficult to balance the cost and equity piece. But to give an example of a state that has entered this, has kind of taken on that challenge, I know Delaware did include certain components that it's kind of using as quasi measures to kind of determine equity and quality benchmarks. So I know that they take a look at things like adult obesity, kind of beta blocker treatment for folks after they have a heart attack, and kind of using that as indicators, mainly looking at the fact that, hey, these tend to have disproportionate impacts on, Black and Hispanic populations, kind of using those as quasi measures. And I think that might be a strong start, at least for other states as they consider entering, or incorporating equity into their cost commission efforts.
Yeah, thanks, Natasha. That's really good to hear. And it's good to hear that that's achieved some success. And just thinking of picking off on that a little bit, states are not antitrust enforcement agencies. The federal antitrust enforcement agencies, for example, don't have the purview to look at these kinds of things, but a state review commission can do whatever the state tells it can do. And for that matter, even a state attorney general has much broader authority. Again, I'm not a legal scholar, so Allison can correct me, and you should, but has much broader authority than do federal antitrust authorities. So things like this, general community well-being, community benefit, equity, those can be criteria that are considered by state entities.
So let me ask you all a question about sector-specific strategies, because there's a few things a few questions in the Q&A about it as well. So are there sectors that you think states can be more or less helpful? So when you think about things like prescription drugs or medical devices or hospital costs or physician costs, are there places where there are specific strategies that have worked well, areas where you think states are just less well positioned to intervene at all?
Just broadly, I think just jump in to say that, right, it's still, prescription drugs are always going to be a little difficult from the state level. Again, lawyers should jump in on some of the jurisdictional questions on sort of price regulation of drugs in the context of federal IP protections and things like that, which I don't feel like I am the expert on. But no, I mean, fundamentally, right, hospitals is just sort of the elephant in the room in terms of where the money is. So in terms of sort of sector-specific strategies, I think that's generally where states want to be focusing. Again, political problems are going to be prevalent, but that's going to be prevalent in physician markets as well. And then you're also just dealing with a smaller piece of the pie here, and so much as like Medicare Advantage costs, which obviously the states aren't really gonna to play as much of a role in. So I think sort of focusing on hospitals is kind of the first and foremost, in my opinion. But yeah.
I would reiterate that. I think that's the area where states can really, they have more levers available to them. And, it is a significant component of healthcare spending. And prescription drugs, I think a lot of states are interested in it, but agree with Lauren that it is kind of difficult to navigate not just the legal issues, but the and jurisdictional issues, but the pricing also. Pricing is done nationally. It's not done on a state by state basis. And so, and there's also really a lack of transparency around what you're actually paying for prescription drugs. That makes it hard for a state to tackle. So I would reiterate that hospitals is sort of where there's greatest opportunity, and potentially kind of leveraging rate review and the ability of insurance commissioners to look at commercial insurance rates as in looking at kind of hospital pricing in the same way that Rhode Island does with its affordability standards.
Just to sort of tack on one more thing on the prescription drug point, I think a lot of folks have sort of focused on, a lot of the state reforms out there really focused on the pharmacy benefit manager or PBM side of thing, of, somehow trying to like get rebates back or get them back from the Medicaid program. I think some of that sort of misses a little bit of how these sort of programs, I mean, most of the policies that states are talking about there actually would be cost increasing, right? PBMs, an insurer wouldn't use a PBM if it wasn't reducing costs on some level. So I do think there's some sort of if you're thinking from the cost perspective here anyway, those strategies I don't think are really the right avenue.
You all have worked on the ground in states and seen kind of the dynamic as states try to address these issues. And as we're talking about states taking on hospitals, I can't help but think about the politics of it, right? The hospitals are like large employers in the states. They're very powerful. The federal government has a hard time taking on the hospitals when we think about things like Medicare pricing. Have you seen more success at the state levels as states try to push back on the hospitals and the large hospital systems to control prices? No.
I think the politics are really difficult. Again, I'm not a political scientist or political analyst, but I think they're very difficult. And I think the politics are tougher at the state level, if anything, than at the federal level. And they're very tough at the federal level. And part of the reason, of course, is that as Lauren said, where's the money? Look where the money is. Well, about a third of all healthcare spending is hospitals, and doctors are 20 something after that. So it's hospital spending. But that means then if states do things to try and reduce hospital spending, it hurts hospitals indirectly. And who benefits? Well, the citizens of the state, employers in the state, but they're diffuse. And the effects on hospitals are concentrated. The benefits to everybody else in the state are diffuse. Even employers in Pennsylvania, for example, like I said, two biggest employers are the state government and University of Pittsburgh Medical Center. And even in Pittsburgh, where I live, we have large corporations, PPG, Alcoa, Heinz. They don't actually have a lot of employees in Pittsburgh. So the politics of this are very difficult. That doesn't mean shouldn't be pushed on, right? We're spending so much on hospitals that it's harming employers, right? If we manage to reduce spending on hospitals, there'd be more money available for employers to pay their workers more, hire more workers, make investments in ways that would benefit them, the people that work for them, and their communities, and would make us better off. But getting there is really difficult.
I will say I am somewhat encouraged by some of the latest activity at the state level to address some of the anti-competitive contract clauses that exist. So I know it was just a few months ago that, Texas was able to successfully pass legislation that eliminated anti-steering and anti-tiering. And, I've heard from advocates there that kind of the perspective they took was really highlighting on the fact that, these are market failures that are happening in our system. And, kind of by banning these particular contracting practices, it's trying to right the ship a little bit. So definitely not a kind of a definitive and conclusive win, but I think it is, kind of an opportunity to just build momentum and make kind of small, minor progress.
I also think that I think the last couple of years it's been hard to do anything with hospitals because of COVID. They were posting huge losses. They were contending with labor shortages. And so it was do not touch hospitals. It's very difficult. You need us. And we're essential workers. We can't take any more price cuts. I think that is starting to turn around as you start to see hospitals and systems become profitable again. And so I think that the tenor, I think, of the conversations are starting to change also.
Yes, that's true. That is a good point. So we have like 1 minute left, and I want to ask you all just a very quick round of questions, which is, what haven't you seen at the state level? What's one thing you haven't seen at the state level that you would like to see?
I guess I'll jump in. I think one, it's not that we haven't seen it. I think it's that we haven't seen it born to its sort of to the end goals here are, I'd like to see a state public option actually follow through on the hospital rate regulation piece. So, right, a number of states have sort of set these premium targets that, right, if premiums aren't growing faster, that are growing too fast, basically the state can come in and reduce hospital prices. I think Colorado's law sets up, I think, a pretty strong process to actually do that. I sometimes speaking about specific states here, I don't know every single state, so forgive me if I'm like missing a state here. But Colorado's process, I think, sets up a strong process here. But will they actually follow through on it? That's the $1 million question. It is very difficult politically, but I am very right. That's a small test case. We're just talking about an individual market. We think hospital prices are lower in the individual market than elsewhere to begin with. But right, I'd like to see that test case even bear out somewhere first. Maybe it's Colorado, maybe it's elsewhere, but actually see if we can reduce hospital prices in one of those, because I think that opens up a good thing for other states to crib from, or the federal government to potentially crib from in the future.
I mean, I'd like to see a state that does have a cost commission actually jump into the new REACH model and just to see how that turns out.
Mine is sort of along the lines of what Lauren said, in terms of that it's not that I haven't seen it, but I'd like to see more of it. I would like to see more departments of insurance focused just on health, like similar to what Rhode Island has. It has an office of the health insurance commissioner that is just focused on healthcare, because I think that that way you could do more around rate regulation, rate review, and use more of the tools that we've already talked about.
I'd like to see price regulation. Now, again, I don't think that's likely to happen real soon. So in the interim, I'd like to see monitoring, oversight, and review with teeth. We do see that in a few places, but I think we need that more broadly. We need the information, and we need it to be examined, and we need there to be consequences if problems are identified. And I like the public option idea. I think that's something that has some merit. Again, the design matters, just like with everything else. But I think those are some things that I think could really have some legs for state health policy.
You all are brilliant. You have a ton of insight and wonderful ideas. I really enjoyed talking with you. I want to invite Rachel Werner back in to close us out today.
Thank you, Allison. I will second Allison's view that you are all brilliant. It was a wonderful conversation. So thanks for taking some time to talk with us today. And thank you, Allison, for deftly moderating that interesting conversation. I want to invite everyone to join us at our next virtual seminar, which will be held in collaboration with Health Affairs. And it is on health equity and the role of racism-conscious policymaking. I hope to see you all there. And in the meantime, have a great weekend. Thanks, everyone.